Hi guys, J.A. Graves here from drjagraves.com. Today we're going to cover the what and the how behind an efficient physical therapy exam of the cervical spine. Let's start with the what. All right guys, we're gonna dive a little bit deeper into the what. So what I've got here is I've got 4 major bullet points of things that we're gonna talk about as it pertains to the what behind your efficient physical therapy exam of the cervical spine. The first thing we wanna talk about is what's wrong. Now, when I use the word wrong, I'm talking about the things that are sinister, the things that we should be concerned about that might warrant a referral. Now, hopefully, during conversation with your patient, you were able to identify anything that may warrant a referral. But if you're not so sure and you just want a CYA, which is always a good thing to do, this is a great time to include any VBI testing or any ligamentous stress testing. Now, you should probably check the ligaments anyway, even if you didn't get any information that might lead you to believe that there could be laxity. VBI is still up in the air, but again, you might just want a CYA. Next, we're going to talk about what hurts. Now, this is probably the most important thing and our most prominent goal when it comes to the physical exam, right? We're trying to identify the patient's concordant sign or asterisk sign. I call it a mechanical sensitivity, but this is critical because this is going to be what we use to audit or check our progress. So in orthopedics, we're taught to test, treat, and retest. Okay, this is our test and retest. All right, so this is super important. I want you to keep this in mind. As we're going through exam, this is a big thing that you're trying to identify with your patient. What is it that actually hurts? All right, next, we want to talk about what's moving well and what's not moving well. Now, this might be just as important as your mechanical sensitivity or figuring out what hurts. Now, in this video, I'm talking exclusively, or for the most part, about the local examination. So what's going on within the cervical spine or the region of the cervical spine. I should note that my examinations, and I'll do this in some other videos and show you guys a little bit more of the comprehensive examination, but we're looking at everything when we're looking at a patient. We're checking out the thoracic spine, the scapulothoracic joint, the shoulder complex, how they move through fundamental movement patterns. So with this, again, this is incredibly important, especially when we take a bigger look at the patient as a whole, but it's incredibly important to think about this too when we're looking at just the local examination of the cervical spine. So again, we're trying to figure out what hurts, right? We're also trying to figure out what's moving well. So in this case, we're looking for movements that might be painless or not hurt, but what we would consider dysfunctional. Okay, and you're going to learn about this when I talk about the how. But it's very important to remember this. We're also looking at not only, kind of on the same lines as what doesn't hurt, but what might be considered dysfunctional, but how do they move in general, okay? Are they competent movers? And we're going to use a little bit of information from the SFMA to help us identify this, okay? And last but not least, what we need to look at is, does what they have match what they need? Okay, now this is a really important concept. What we're talking about here is capacity. Okay, so hopefully in the interview you were able to gather information from the patient in which they told you what it is that they need in their life. Now this comes down to their physical needs. So what do they do for work? What do they do for recreation? What do they do for fun? What's their physical activity level like? And what we need to try to identify is if what they have matches what they need. So are they able to withstand the stresses of life? And again, this is what we call capacity, all right? This will come into play as will this, what's moving well, a little bit more with the global examination of the patient as a whole. Again, that won't be talked about in this video. We're really just focusing on the cervical spine exam locally without getting into some of the more regional interdependence approach that I take here. All right, so now we're going to talk about the how. All right, so now we're going to talk about the how behind the what. All right, so looking at the exam here, I briefly mentioned this before. We have what we call a functional exam, which this takes more of a regional interdependence approach where we look at the entire person. So again, we're looking at the thoracic spine, the scapulothoracic joint, how does their lumbar spine move in their hips, how do they perform the basic training elements or the fundamental movement patterns of life, push, pull, hinge, squat, carry, lunge, twist, anti-twist, right? All of these things. These are part of that functional exam. Now, even with somebody with neck pain or TMJ problems or headache, we have to include a functional exam. Again, that's beyond the scope of this video. We're going to focus on the show me exam and the local exam. So the show me exam is pretty straightforward, okay? Show me what hurts. Now, if you've experienced this in the clinic, you know that a lot of times people will show you some really awkward positions and you can't help but ask yourself, don't ask the patient, but when do you actually get into that position? There's still a lot of value in this because it helps you see what it is that hurts the patient. Now, sometimes people do this in the physical therapy exam by trying to palpate or do a joint assessment or something like that. I think there's a ton of value and we get a little bit more information by actually just having the patient show you. Have them show you the movement that hurts. And I would be a little bit cautious if they start just pressing on their neck and saying, well, it hurts right here when I press on it. We really have to figure out what is the functional problem here, right? We are treating function, okay? We tend to get caught up in pain, but we really should be focusing on function. So this is a really good opportunity for them to just show you. Okay? If they're a hairdresser and their neck hurts and it's because they're hunched over somebody like this all day and they say, well, it hurts when I'm in this position, that tells you a lot of information. That might clue you in to where you want to spend more time during your functional exam. Okay? So after the show me exam, we're going to break out into our local movement exam. Okay? Now this is not going to be too novel for you guys, but there will be some gems in here I think that will be really helpful. So obviously, we've got our active range of motion, our passive range of motion. It's important that we check out motor control. Breathing is something that I check on everybody. And quite frankly, we might be able to say that that belongs up here. But with the cervical spine, I have found a lot of the times there to be a massive correlation between a dysfunctional breathing pattern and somebody's pain. So I will check that all the time, okay? And I'm going to include that in this video because I believe it's that important. And lastly, we're going to look at repeated motion. So we're going to look at what either repeated or sustained positions, postures, or movements does to a person, to elicit a person's pain, or simply just to identify any painless dysfunction, or again, a movement pattern that is not necessarily painful, but dysfunctional by our standards that we might be able to work on to help resolve their mechanical sensitivity. All right, guys, we're going to dive a little bit deeper now into the how behind the what. So we talked about, we have our functional examination, our regional interdependence approach. This is diving deeper into our local movement-based exam, okay? So what we want to do here is we're going to go from standing to sitting to supine, all right? First thing we want to look at, cervical flexion and standing, okay? I'll talk a little bit more when we get to supine about the value of looking at this movement both actively in standing and actively in supine, because you're going to see we look at the same thing with the patient lying on their back. Next thing we're going to look at, cervical extension. Now, one thing I want to talk about with extension is it's important that you break out the extension components, okay? So one of the things that can happen is somebody might look up and say, yeah, that hurts my neck, that produces my pain down here. And we're like, okay, next, right? We move on to the next test. A really neat thing you can do to break out, basically try to figure out what component of the cervical spine is affecting that, whether that be the upper, the mid, or the lower cervical spine, is by simply doing some different movements. So if this hurts, it might be of value to just have the patient jut their head forward and look up a little bit. Okay? Now what that's going to do, that's going to look at the upper cervical spine. Is the upper cervical spine causing the pain in their neck with extension? If they have pain when they do that, well, no. It's either upper cervical spine or it's not. Let's go ahead and say that it's not. So they do this and they're like, yeah, that doesn't really bother me. How are we going to check for the other areas? The easiest way to check for the lower cervical spine is to have them do a chin tuck with extension. So from the side, that's going to look like this. Okay? Or from the front. Okay? Now again, a simple, hey, does that reproduce your pain? If they say yes, great. We can be pretty sure it's the lower cervical spine that's causing their problem. If upper cervical was negative and lower cervical was negative, by process of elimination, we can say that it's more than likely their middle cervical spine. Okay? The next thing we want to look at is rotation flexion. All right? So what that's going to look like is turning your head to the side and bringing your chin to your collarbone. Okay? Now, the folks from the functional movement system who created the SFMA have said that if a person can get their chin to their collarbone, they're probably doing pretty well. I use the same criteria, all right? So if they can go from here to here and they can touch their collarbone without shrugging up, we're gonna say that's pretty good movement, okay? So those are the standing tests. You can see, pretty simple. I don't need to look at much more than that in standing, again, when I'm just looking locally at the cervical spine. We're gonna take it now to sitting. So in sitting, we're gonna first look at their breathing pattern. This is a really good opportunity to get behind the patient and see what type of movement they have through the ribs and through the chest and through their upper back when they're breathing. So basically how they're gonna be set up on this is they're gonna be sitting on the edge of the table facing away from you, and you're gonna be behind them, and you're feeling the ribs. You're feeling for, whether they're getting some good lateral expansion or if the ribs are just going up. If you're also observing this happening at the same time, okay? These are important things to look out for. It's nice to look at it in sitting and in supine, which you're gonna see, we're gonna look at breathing with the person lying on their back too, because in sitting, they technically are in a loaded position, right? They have the weight of gravity coming down on them. They're supporting the weight of their head. This can change movement patterns dramatically. Again, this is why we look at cervical flexion both in standing and in supine. All right? So sitting, we're gonna look at breathing. The next thing we're gonna look at is we're gonna look at repeated motions. All right? So what does repeated neck protrusion do for them? So if they do this 10 times, what does that do to their pain? Okay? And they might do 10 of those and be like, nah, it doesn't do anything. Okay? You might need to do this 1 or 2 more times to see. And this is where, again, asking good questions in the beginning can become helpful for you, because they might tell you that it takes a lot for their neck pain to come on. You might have to do a lot of movement here to elicit those symptoms. So we're gonna look at protrusion of the neck, which I just showed you. We're gonna look at retraction. So that's here, straight back, okay? And again, you're gonna look at this movement 10 times. You might look at it 20, 30, 40, 50 times before you get the information you need, okay? What we also want to look at with repeated motions is we're going to check rotation. So you're going to have the patient do a little bit of a chin tuck and then turn as far as they can. Okay? You're looking for quality of movement, and you're also looking for any reproduction of symptoms or any asymmetry side to side. Okay? Now, quality of movement, is it aberrant movement? Are they shaking when they do it? Well, that's not normal. I think we can all agree on that. And can they only go, this far? If that's the case, we know that there's some rotational deficits that we might want to address. We may choose to address those with repeated motions as a treatment, or we might just put that in our notes and say, okay, I want to come back to this later on, all right? We also want to look at repeated side bending. So again, slight chin tuck and tilt. Now what's important here is that the person gets pure frontal plane movement, okay? So a lot of times you'll see chin tuck and they kind of look down, or they kind of do something like that. We're looking for a pure lateral flexion, all right? So again, we're gonna do 10 of these each direction, and we're gonna decide if this is relevant or not. Does this give a reproduction of the patient's mechanical sensitivity or their concordant sign, or is it just suboptimal? And if it's suboptimal, but it doesn't hurt, this could be a great starting point for your treatment. Again, that's what we're looking for with the, what moves well portion of the exam. So now, from sitting, we're gonna transition to supine. So in supine, again, we're gonna look at breathing. We're gonna look at what moves first, what moves more, their upper chest or their belly. Do they move simultaneously? Does their belly move at all? Or is it all just the chest, right? And then also, does this happen? Do we see just a general elevation of everything? We're gonna observe the hypertonicity or the activation of some of our cervical musculature that might be serving as a primary respiratory muscle when in fact they should be secondary respiratory muscles. So again, breathing is very important both from a sitting perspective and supine. You might see really dysfunctional breathing in sitting, but not bad in supine, and that tells you when they're under load, their breathing pattern is more dysfunctional. So we might have to find some strategies to improve that, and that may not include just having them lie there breathing, okay? Again, we're gonna look at cervical flexion again. Now we're gonna look at it actively while they lie on their back. We looked at it in standing under a loaded posture, right? They've got the weight of gravity, the weight of their head, they've got all these stabilizers in their body that are trying to work to keep them upright. If active flexion is better in supine, whether that means it doesn't hurt or it moves better, they probably have a motor control, stability, or postural problem, postural control rather, that's allowing them to move better without load and worse under load. Now, if this doesn't move well actively, let's check it passively. But if it moves well actively, we don't have to check it passively. Again, we want this exam to be efficient and we want to get the most bang for our buck. We are trying to find the low-hanging fruit here, right? What is the one or two things that really stands out in the exam that we can start treating right away? Again, this is why I'm such a proponent of movement versus manual therapy examinations, because we tend to get a lot more information and it's more relevant, it's more functional, okay? So again, if active flexion is great, you deem it to be really good with them lying on their back, they don't have pain, and they can get their chin down to their chest, you don't have to do the passive part. Next, we're gonna look at rotation. Now, I didn't write this up here because I'm a human and I make mistakes, but this would look very similar to the flexion, okay? So if somebody has problematic rotation in standing, we want to see it actively in supine. All right, there's a lot of value here. Again, if they can't do it loaded, but they can unloaded, there's probably some type of stability or motor control deficit that is limiting their ability to do it in a loaded position. Now, if it looks really good in standing, you don't have to look at it in supine. If it looks bad in standing and it looks bad actively in supine, let's check it passively. Do they have the hardware? In other words, do they have the physical capability of getting their head rotated, right? Now, if they can't do it actively, but they can passively, we're gonna say they have the hardware. They have the capacity to move their head into full rotation. They just can't control it themselves. So they have the hardware, they don't have the software, okay? Next, we wanna see what the upper cervical spine is doing. So we're gonna take their head and we're gonna have them turn all the way as far as they can one direction into rotation and then nod. So we're trying to identify if there is an upper cervical problem here, right? Do they have difficulty with capital flexion, all right? Now, very similar to what they did in standing, here and here, okay? But again, we're unloaded. So we just wanna see if there's a difference between being in standing in a loaded posture versus being supine in an unloaded posture. Okay. Next, we're going to look at the cervical flexion rotation test. So we're going to look and see, is there rotation deficit upper cervical or not? We know that we get a lot of movement, it's about 50% or so of our rotation from C1, C2. Again, if rotation is good in standing, or it's good, you're not going to check it again. If it's bad in standing or good in supine, whether active or passive, there's no need to check this. We don't have to. If they have sufficient movement, we don't need to go any further unless it's painful. We might want to check it if it's painful. Okay, so if they had painful active rotation but it was full, passive was full and still painful, we might want to see if that's a C1, C2 problem. And we're going to do the cervical flexion rotation test. Okay, what that test is, the patient's lying flat on their back. You're going to take them into maximal cervical flexion, and then you're going to take them into pure rotation side to side. You're looking for a reproduction of their symptoms, or you're looking for any unilateral loss of movement. Typically, you don't see bilateral losses, especially if they have a unilateral problem, such as pain or headache, but sometimes you can have bilateral problems, okay? All right, so now we're moving into extension. We checked extension and standing. We broke that out through upper cervical, mid-cervical, and lower cervical. And if you didn't like what you saw because you felt that there was a movement limitation there that didn't quite meet your standards, and again, if we go back to the SFMA and we look at how they gauge this, they want to see that head and that face be within 10 degrees of parallel to the ceiling. So if they're not there, you might choose to look at this passively. This is really simple. Have the patient slide to the edge of the table, take their head, and extend it off the edge of the table, okay? And here you're looking for pain, you're looking for, do they have a lot of movement or do they have very minimal movement? And if they have minimal movement, you may have found your problem, okay? The last thing we want to look at is motor control. So we're going to use the Yonder neck flexion test. This has a bunch of different names. I learned it as the Yonder neck flexion test, but essentially the patient is going to be supine, lying on their back, and they're going to try to look down at their belly button or down at their feet. What we're looking for here is, do they get good flexion from the upper cervical spine and the lower cervical spine as one unit? In other words, can they actively use those longest capitis and longest coli muscles to flex their head, or are they compensating with their sternocleidomastoid, their SCM? So how are we going to differentiate? If they get nice pure flexion, okay, we're going to say, wow, you have great motor control of your deep neck flexors. Good for you. What you'll see often, however, is that people will go to look at their head, or go take their head and try to look at their feet or their belly button, and you see this. And we see a little bit of a protrusion moment, more of a protrusion than we see flexion. You can often see and palpate the SCM being very active during this test when it's dysfunctional. But if it looks good, it looks good. Move on, okay? So I want to talk a little bit more about this as a whole and explain to you why I think it's so valuable to do this basic movement exam versus adding in unnecessary manual therapy components. All right, guys, I want to wrap up, and I just kind of want to clarify some information from what I talked about today and tell you a little bit more about why I find this approach so much more valuable and so much more efficient than excessive manual therapy examination components. So what's really important to take away from this is that when we look at people, we should be looking at function. We've got really caught up in the physical therapy world being about pain. I feel like we're almost pain managers, and I won't go on a rant here, but we should be focused on restoring function. And we need to help our patients understand pain. Pain science education can be a very important part of our treatment plans, and we need to shift the focus to function. We have a crisis on our hands when it comes to activity levels and the general health of our population. We are in a really good spot, and we have a really good opportunity to make a huge impact in this world when it comes to physical health and physical function. What we find, though, which is really cool, is that when we focus on that, we do see pain start to go away. But we have to be transparent with our patients that, hey, you know what? Motion is the answer, exercise is medicine, and we will see pain reduce. More importantly, though, we need to focus on your general health and your physical activity. With that, we'll see improvements in function, we'll see gradual decline in pain. I see it every day, okay? So that's why I'm such a big believer in this. The other thing too is, let's think about what it is that we're trying to get out of our physical exam. We're trying to figure out what's going on with the patient, right? Why do they hurt and where do they hurt? And you're best going to analyze that through movement, right? Because it's not like somebody just sits around all day and they're like, well, yeah, I only have neck pain if I push on it. So if we go and we push on it and it produces their neck pain, or we feel like we're feeling something that's tight, that doesn't match up with function. So let's look at the movement, let's look at their functional movement patterns and identify where the problem is, okay? So what we need to be thinking about here is, where are we gonna get the most bang for our buck? Another thing that I read recently that I really like to kind of think about is, let's do less better, okay? Let's get less information, not get less information, let's do less diagnostic testing. Let's do the minimum viable product, right? Let's do as little as we need to get the most information as we can. Now, I'm not saying that gathering additional information is not important. Again, I utilize a functional examination with all my patients in which I look at everything from the big toe up to the neck, no matter what they have going on. So again, this video was more about the cervical spine and the local examination there, but what can we do? How can we best utilize our time? Okay, our time is best utilized, in my opinion, by getting the most bang for our buck, right? Not doing a bunch of unnecessary testing. Let's use a condensed examination and let's do less better. Let's get better information with less, okay? It's gonna confuse the patient a lot less, it's gonna confuse you a lot less, and it's going to help you plan your interventions much better, okay? So again, when it comes to the manual therapy part of the exam, again, I just think that we tend to get too much information that doesn't tell us much. It doesn't really give us any information on how the patient functions. I'm not even sure that it necessarily corroborates the functional patterns that we're seeing, because I think a lot of the times we might be feeling what we want to feel. And this is coming from somebody who used to use a lot of manual therapy and used to use a lot of manual therapy in my examination, and now I've shifted to a lot more of an active-based approach, and it's been really cool to do that. Okay, so in closing here, I want to thank you guys first of all for watching. Hopefully you found this valuable. Hopefully these are some things that you can take back into the clinic with you if you're practicing. If you're a student and you've got upcoming rotations, hopefully this is something you can take with you onto your rotations. And I challenge you to use this approach and to minimize the hands-on contact with people and see if your outcomes or your confidence improves. And I do think that it will. I think that sometimes we just get too caught up in the manual therapy stuff. We're not sure what we're feeling, so we get kind of like, I don't really know if that's there. I'm going to try to treat it. You're kind of throwing stuff at the wall and trying to see what sticks. And kind of piggybacking off of that point, one more point I want to make here is that there's no singular lesion. And what I mean by that is if you've done a movement examination, you decide, I want to start palpating and doing some accessory mobility testing and seeing what PA and AP and transverse glides feel like, you have to remember that is not a singular problem, right? What you feel in the joint is not singular, okay? What I mean by that is the joint is controlled by muscles, right? The joint stabilizers are going to be what controls mobility and movement within that joint. What controls the muscles? The central nervous system. So here we have a dynamic interplay between the central nervous system, the musculature, and the joint. So if we feel something in the joint, we would be doing our patients a massive disservice if we just focused on the joint. I would almost argue we need to go back to the central nervous system and start there, or start at the musculature and then see what happens at the joint. We're going to do a lot of really cool things with this approach by doing that. We're going to have the patient become less reliant on our hands. We're going to have them become more empowered and more comfortable using movement as an intervention, and it's going to help us not be so confused and not be so bogged down by the manual therapy information that we get or that we think we get, thus boosting your confidence and more than likely boosting your outcomes and patient satisfaction. So hopefully you guys enjoyed this. This is one of many videos to come and trainings and courses that will be coming out in the not so distant future. Again, Please keep in mind, this was just a local examination of the cervical spine. We should be taking a regional interdependence approach. We should be looking at the thoracic spine, the scapulothoracic joint. We can look at different breathing patterns or different positions for breathing. And again, we need to be looking at the fundamental movement patterns of life with our patients, with every patient, okay? Pushing, pulling, squatting, hinging, lunging, single leg activities, carrying weights, and twisting or anti-twist, or how do we control our torso in the presence of a perturbation or a challenge. So thank you guys for tuning in, and if you haven't checked out my group on Facebook, it is called Fresh PT Clinical Mastery. We talk about clinical cases, we talk about strategies to make you more confident, to increase your knowledge, and to give you the skills for clinical mastery. So check that out. Again, Fresh PT Clinical Mastery on Facebook. You can follow me on Instagram at drjagraves.dpt. And you can check out my website, drjagraves.com, or Facebook at drjagraves. Thank you guys, and we'll see you soon.